So the agenda today is first talk about why handover is important. Second, what are the current standards and guidelines? And third is about what tools are available for handing over and how to implement the best practices. So for this presentation, I have stopped using handing over and used the term handover because it's much easier to pronounce it. Okay, so there is handoff, handing over, handover. No, all these things are meaning the same. So what is a handover? So handover is the transfer of professional responsibility and accountability. So basically, that's what we do when you do a handover, and it is maybe for some aspects of care, or all aspects, or it may be for a particular patient or a group of patients. So if you transfer a patient from one hospital to another, then it is all aspects of care and it's for a particular individual. But if you're doing in the ward, then it becomes for the group of patients, for the whole ward. And finally, this handing over is taken is given to another person, such as a clinician or nurse, or a professional group. That is, it could be paramedics to the clinician, like that, and it could be for a temporary or permanent basis. So for example, if I'm going on a 2 days off, I may hand over my patients to my colleague. It's only temporary. I'll come back and take over the patient. So that is handover. And the cornerstones of handover are three things. One is partnership, two is accountability, and the third is transparency. Now, what do you mean by partnership? So first is partnership with your own staff and also partnership with the patients. So we introduce ourselves and ask others to introduce themselves. So though we know each other, I think sometimes there may be strangers, who maybe somebody's doing a locum or something like that. So it's better to introduce oneself and get used to everyone, and explain the process. When you're in front of the patient, explain that we are doing the handover and explain the process and obtain the patient consent before we do in front of the patient. So that is partnership. The second is accountability. The most important aspect of handing over is accountability. So we become accountable for handing over what all we did in the last shift to the next incoming person. And before leaving, you need to make sure that we do some certain patient safety checks so that the patient safety is safeguarded. And finally, transparency to the patient and the families is very, very important. So that is the reason we are doing the handing over in front of the patient. Though we may not say certain sensitive issues or confidential things in front of the patient and relatives, that will be done outside the room. But as far as possible, the process has to be transparent and the patient knows what is going on. So these are the three cornerstones of handing over. Now, it's very interesting to see how often does handover happen. That will tell us why so many mistakes happen and so many communication errors happen. So in a particular admission, if a patient stays for 5 days, handing over happens almost 15 times. That's pretty simple maths, right? 3 times a day into 5 days. And for the doctors, for a month, they can actually be, or nurses, they can be involved in about 3,000 handovers in a month. That's a huge amount of communication which is going on in the hospitals. And that is the reason, if you are not careful, a lot of mistakes can happen and patients fall between the cracks. And many hospitals, only verbal, almost more than 50%, only verbal handing overs happen. There's no documentation at all. And more than 34% of nurses, in particular study, reported handover is not actually sort of timetabled into the schedule. So it is like you have to do all the work and somehow manage the handover. So if you do that, then the handover will become rushed because there's no time actually scheduled for the handover. So these are the facts. And you can see here that this is the reason why, there are so many places in which the handover has to happen. It's like from the home to the GP, or if they're coming to the emergency, to the paramedics, and then the GP refers the patient to the hospital, or the ambulance brings it to the emergency room. So this handover happens here. And inside the hospital, in the acute medical unit or surgical unit, every day, as I told you 3 times, and the ICUs, maybe much more frequently, this handing over is taking place. And then if they're transferring to another hospital, that handover also can take place either from the emergency off from the ward. Then we're going to discharge, you're actually handing over the patient to the relatives or to the home care nurse or something like that. And if they're going to a long-term facility like nursing home, again, handing over takes place. So there is so many opportunities for handing over and so many opportunities for error also. So this is the problem with handing over. Now, there is a failure in handover is a major preventable cause. As we all know, if we are doing it properly, then we can actually prevent the errors. And two main causes are there. One is poor communication, another is system errors. So basically, the handing over or handover system is not well established in your hospital, and that is the reason it is happening. There is no point blaming the nurses or doctors saying that no, handover is not done. We need to spend time to put in the systems in place. That's very, very important. And there are several patient safety issues like delayed decisions, repeated or delayed investigations, incorrect diagnosis or treatment, not receiving the required treatment, poor communication with patients and relatives, and all the other usual errors like medication, patient falls, ulcers, pressure ulcers, readmissions, and even deaths can happen because if the handover is not very good. So that's about the introduction to handover. Now, I told you, why is handing over important and certain facts about handover. Now, let us get into the current guidelines. So several organizations have put in guidelines. Here, we cannot say we don't have guidelines. So Royal College of Physicians, NICE, that is the National Institute of Healthcare and Excellence, JCI, and the Royal College of Surgeons of England, and many others have guidelines. I've chosen to just highlight these four. And all of them will talk about multi-professional team activity. That is the actually foundation of handing over, which makes sure that there is not only vertical transmission of information in between the various specialties like nurses, doctors, and other paramedical workers, but also there has to be a horizontal communication happening, and that happens only when there is a multi-professional team activity. And it's very important to have a standardized handing over policy. So first is, as with any other system, you need to sit down and put down your hospital policy and write the manual. So, is that it has to be written down. It should be based on the guidelines, which I pointed out. Then, based on the policy and manual, you will create training material and train the nurses and doctors. And while using the guidelines, feel free to tailor it to the local unit and needs. For example, the handover which happens in the emergency is totally different from the ICU, and that is totally different from what happens in the wards, because that is the nature of the work which happens in each of these departments. So not only you tailor it to your hospital, each unit has to tailor their handing over according to their priorities. And we need to, as I told you, have a designated time and location where this handing over takes place, at least starts. So the start time is so much, and it will be starting in this place so that everybody knows where to assemble and what time to come. And finally, very important to define who must be present, including the seniors. So I'll be talking about who's to lead the handover. So the person who's leading the handover should be the first to be present. Okay, so these 5 are very important before we put the systems in place. And most of the time, handing over takes place without thought, and take time to put these 5 things in place. Now, where should handing over take place? As we discussed in the poll, it can happen outside the room and at the patient's bedside. So both places, handing over has to take place. And outside the patient room, incoming nurse and doctor or outgoing nurse and doctor are involved, and it may take place in the nursing station or in the doctor's room. So, or it may be just outside the patient room. It's all up to you. So, but it has to be defined. And inside the patient room, again, the incoming and outgoing nurse or doctor will be involved, but make sure you involve the patient and the family. Very, very important. So just don't stand there and keep talking and ignoring the patient and the relatives. Now, you've got to explain to them what you're doing and get them involved. So you should also know to cut off unnecessary conversations. I know that's the knack of any healthcare professional. So sometimes many relatives may be talkative, so you need to know how to get focused on your work. So it should take place at the patient's bedside. Now, this is what I told you. Once the handing over is completed in the patient's bedside, and when you come out of the room, make sure you follow this minimum safety checks. So these are the 5 minimum safety checks which has to be done whenever a nurse comes out of the room, or when the handing over is done. So look at the IV site and fluids. Is the site is the is the cannula in place? Is the correct fluid going on? Look at the allergy bands and wristband. The identity bands, are they in place? Are the bed rails again raised? And is the bed in the lowest height? And is the nurse call button within reach? Not only nurse call button, whatever the patient needs, maybe the spectacles or hearing aid or newspaper, water, make sure it is closer to the patient so that the patient doesn't need to get out of the bed, and thereby you will decrease the incidence of falls. So these are the 5 minimum safety checks, and this has to be done after you finish the handing over. Now, I'm getting into the process of standardized handover process. So now this is what you have to write in your manual, how the handing over process is going to happen all over in your hospital. So these again are the 5 steps. Who is the lead? Who's going out and who's going in? They should be identified. What is the sequence of the handing over? What are the tools you're going to use, or what is the tool you're going to use? And how do you document, or where do you document it? So these 5 things have to be defined. So and also, as I told you, you have to include the patient risk assessment at the end of the handing over. I already told you about the 5 minimum safety checks. Involve the family and the patient, already mentioned. And very important, we need to audit this process. I told you that it is happening 3,000 times. We are 300 times we are getting involved in handing over, and it happens in all the wards and various specialities. So this is a very important place to audit and make sure mistakes do not happen. So let's take it one by one. Who is the lead? So it must be the most senior clinician available. Need not be the head of the department or the lead consultant, but at least someone who is answerable. So that means the most senior clinician can be the senior registrar or junior consultant, whatever, according to your hospital policy. Senior most nurse in that particular shift, they should be leading this handing over. I want to share my experience in the UK, where every day at 7:30, there used to be 7 units in the in that particular hospital I worked, and at 7:30, representatives from all the 7 units will assemble. And the on-call team, it was a responsibility of them to write in the board the new admissions for that particular night. And then they will go through each one of these cases. And some of these cases may have been belonging to some of the units. So that will be, the transfers will take place at the same time. And the most important thing is any one of those team members actually will be on call and in the following week in the night. So they get an idea every day, that what are the new admissions which came in, what is the status of the patients, and it takes only 15 to 20 minutes. So if it is properly planned. So this is something which used to happen every day, in the hospital where I worked, and this is something I think which we need to, especially clinicians, we have to. Nurses to some extent they are already following the handing over, but I think it is patchy as far as doctors are concerned. That is my impression. Now, very important to document who is going out and who's coming in. So make the introduction, identify that, and document it. The next is what is the sequence? So the first thing is, I already told you, the place and time. So where it is happening, what is the venue, what is the start time, and the team, the handover lead, and the participants all should be assembled. That is the step 1 of handing over. The second step is the ongoing chain of care. Make sure that the information is passed from the outgoing team to the incoming team. And as I already pointed out, it is ideal that if it is a multi-professional team. So I see some hospitals are practicing it. I'm really happy. Our own hospital doesn't do that. So what happens is then it becomes like silos, like compartments. So when there is no horizontal communication, then patients fall between the cracks. So combined nursing and doctor's handover to start with, and later you can involve physiotherapists, dietitians, and other professionals who are taking care of the patients. So then it becomes a real multi-professional team approach. Now, how do you, then the third step is risk assessment. So now this is a very important aspect. I really want you to pay attention. So when we hand over, we just give a list of patients and then walk out. Here, this particular system, which actually the Royal College of Physicians has recommended, is when you hand over, you do a triage of the patients whom you are handing over and do risk assessment and color code them according to the sick patients who need special attention, and if there's any transfers pending, which is it has to be done, or it has when there has been any death in the previous shift. So these things have to be looked at. Now, the other concerns also, if there is staffing concerns, if there is less amount of staff, or somebody is sick, or if some equipment has not been working in your shift, so these things can be handed over, especially night shift. They may not be able to get the biomedical or engineering to repair it. So it's very important to hand over such issues also during the handing over. Now, I'll talk about triaging and risk assessment a little bit later, but let's go with this flow. So the sequence I already told you, the start, the venue, and then who's coming in, who's going out, and what are the things you present handover according to the chain of thing, and what is the sequence. And now we are talking about the tool, the various tools available. So I'm not going to go into detail. Now you can always refer them. The most common, we already did a webinar on this, SBAR, situation, background, assessment, and recommendation. Then there is a SOAP tool where you talk about subjective, what the patient is saying, objectives, what we found out, assessment and plan. PACE is patient, action, changes, and evaluation. So this patient, what action I did in the shift, what changes in the patient has happened, what is the minimum evaluation. And the fourth one is IPAS, where we talk about illness severity, patient summary, action list, situational awareness and contingency planning, and synthesis by receiver. So simple to complex, tools are available. So you can just look at it. Now you know the names. You can find out more about it and start using it. So this is all used in inpatient. Now, pre-hospital or trauma patients is totally different tools are used. Ample, I think most of you would be familiar. This is the thing which is used in ATLS, allergies, medical history, pregnancy, last meal, and event which caused the injury. Then there is one called ASHIS, that is age, sex, history, injuries, condition, that is the vital signs, clinical status, and then expected time of arrival. So this is the paramedics use it quite a lot. And then AT missed is again transfer from the ambulance to the emergency department, age, time of incident, mechanism of injury, injury sustained, signs and symptoms, and treatment given. So as I told, there are several tools, so you can use one of them. But what tool I'm going to suggest is very, very simple. So just hold on for that. So the another thing which I wanted you to look at is what is known as patient whiteboards. This is a very important tool which there in each and every hospital in the West. So here you write down the name of the nurse who's going to take care, the doctor in charge, and the various things like diet, fall risk, and if they're on oxygen, what is the pain level, and what is the plan for the day. You talk to the patients and relatives and say, okay, what is the plan for you today? And the patients have certain goals and to achieve it. And then the patients also can write their questions so that they don't forget when the doctor comes on rounds. So it's a very, very important tool. It helps you on rounds as well as in handing over. So I'll also show you a small video in the end where they use this tool and you'll understand more about it. And as the NABH digital standards have come, so that's why in the right I showed you the digital board. Before it used to be a whiteboard. That's a whiteboard. I think slowly it will become patient digital boards. So it's already come in the market. So risk assessment. Okay, so we talked about the tool, and let's talk about risk assessment before you get into documentation. So color coding of patients, red, amber, green, like the traffic light. This is the RAG model. So green means if you're following the Muse score or modified early warning score, 0 to 4, there is no criteria which means which is there for sepsis, then this patient should be reviewed by the junior doctor within an hour. White, of course, doesn't come in. Amber is the news is more than 5 or 3. That is the red score in one parameter. And there is no criteria for sepsis. Or if you think the clinical judgment, it may be the score may be for green, 0 to 4, but you think it doesn't fit with green, then you can put those people in amber. And it should be reviewed by a core training. I mean, this is in UK language. Here, it is an experienced person should be reviewing the patient in 30 minutes. The red is news of more than 7. Our criteria for sepsis is there. Immediate review has to take place, either by the junior doctor or the senior registrar within 30 minutes. So you can see how the incoming team, their job is made easier by prioritizing the care. So they can make sure they first go and see the red patients, then the yellow patients, and then the green patients, you tell the doctor to review, and then you can do your routine rounds. So very, very important for prioritizing this color coding and risk assessment of patients while handing over. So then finally, we come to document, most important. So if you don't document and you do verbal handover, then when something is missing, the blame game will start. So documentation is very, very important. So let me show you just a very simple way of documenting the handover process. So again, this is taken from the Royal College of Physicians. So this is the total sheet, handing over details, ongoing chain of care, the process which we talked about, number of patients handed over in the red, amber, green methodology, special attention, and who are all present and what is the role. And there is some audit happening also. So I will go into that in a little bit I'll magnify it. So first is the ward, the handover venue, date, start time, finish time, duration, and who was the handover lead and was he present. The second is the who's outgoing senior doctor, who's outgoing incoming senior doctor, similarly outgoing. So these are the people who are leading it and they're responsible for the whole handover. And this is the actual handing over. So you stratify the patients according to the color coding and say how many patients are in red, how many patients are in amber, how many are in green, and you write the names of the patients who are sick and patients who have transferred or death has occurred in the previous shift and any staffing or equipment concerns. So you can see how very simple you can do a very comprehensive handing over and document it also. And finally is I told you, the handover has to be audited. These 3 questions, did the the handing over take place within 2 minutes of schedule? Yes, no. Were there any interruptions? Suddenly one senior doctor comes on rounds, the whole handover will get disrupted. Okay, so was there any interruptions? You can't avoid it, but at least you audit it. And then the relevant documentation when you are handing over, the notes and everything or investigations, was it available or some of it is missing? You got to say yes or no. Very simple audit, but at least these things get audited. So this is the documentation part of it. So I think what's the time now? I think we are about a little bit more. Is it okay? This is a 4-minute video. I think it's very valuable. Let us go through it. I hope you wouldn't mind that extra time. So I'm going to just play that. I got to make sure whether the volume is there. So let me just stop sharing. Make sure that the audio is there. Share screen. Yeah, share. I forgot to do that. So let me do that now. Okay, I think now you should be able to see the video.
Before we go in, Margot had a CAT scan of her chest early this morning and it showed some abnormalities that she is aware of. Dr. Massey will be up later to discuss those results with her. Just know she's nervous.
Okay.
Margot, my shift is coming to a close and it's time for bedside report. This is your new nurse, Patty. She's a great nurse. I'm leaving you in very experienced hands. And this is Audrey, Margot's daughter.
Hey, nice to meet you both. I'm replacing Sandy and I'll be with you till 7 a.m.
We're going to start report now, so feel free to add any information or ask any questions. Margot Carley is a 56-year-old that came through the emergency department and admitted for pneumonia.
Okay, Margot, can you please state your full name and date of birth?
Sure, Margot Carley, 6/26 of 60.
Thank you.
Margot presented to the emergency department early this morning with difficulty breathing, cough, and chest pain. She had a room air oxygen saturation of 84%. She has a history of a recently treated pneumonia, and we are currently giving her IV antibiotics and IV steroids through a PICC line on her right side that was placed this morning after multiple IV attempts. She also has lactated ringers running at 125 an hour.
Okay, Margot, I'm just going to check your PICC line here. Yes, and we have this, and we have lactated ringers running at 125.
She was given a Norco for pain about 2 hours ago. How is your pain right now?
I would say it's about a 3. I'm feeling much more comfortable though.
She's also been started on breathing treatments. She recently had a neb. Did you find that effective?
Much, much better. I was feeling really short of breath earlier, but the treatment really helped.
She does seem to be breathing better now, but I'm wondering when the doctor will be in so we can talk to him about her CT results.
Your hospitalist, Dr. Massey, will be in later this afternoon to discuss the results of that CT scan.
Okay, I'll be sure to stick around so I can ask him some questions.
Margot did have an x-ray and CT of her chest and is looking forward to discussing the results.
Okay, Dr. Massey is great. He does a good job at answering questions and will address your concerns while he's here. Once I'm done getting shift report, I'll check on the status of when he's able to get here.
Thank you.
I appreciate
Margot has a oxygen saturation of 93% on 3 liters. Today we're titrating to 92.
Okay,
Her oxygen demands did increase while she was up. She's walked the hall twice and did well. She's tolerating her cardiac diet, although her appetite is poor. She had a BM this morning and is voiding fine.
okay, how are her labs?
She does have a white count of 12, which indicates an infection. Other than that, her labs were fine. And she has a VTE score of 6. That's the risk for blood clot. She's got the compression sleeves and medication ordered for prevention.
Okay, I'm just going to be checking your SCDs here,
Okay.
Margot.
She's at a moderate fall risk with the yellow socks and wristband in place, and she's been using her call light appropriately and gets up well with 1 assist.
And the band, and we have the palette. Great.
That ends my shift report. Any questions, Patty?
No, thanks for a great handoff.
All right, any questions, Margot, Audrey?
Not that I can think of.
I think I'm set.
All right.
Margot, you can expect to see me within an hour for your assessment, and then I'll check on you hourly through the night. Be sure to use your call light when you need to get up to use the bathroom or for any other needs you might have through the night.
Okay, sounds
Okay?
good.
Thank you. Okay, Margot, I'd like to update the board at this time. Is there any shift goals that we can add at this time for you while I'm with you?
Well, besides talking to Dr. Massey, I would like to get some rest this evening.
I think that's good. We should also add an incentives barometer as a reminder for her to use it 10 times an hour.
Times 10 an hour.
Okay, Margot, thank you for letting me take care of you today. Patty will take over now, and I'll be back in the morning.
Okay, great. It looks like your table is within reach and there's a clear path to the bathroom. So just be sure to use your call light when you need to get up to go to the bathroom or for anything else you might need.
Okay,
Thank you.
thank you, girls.
Thanks.
Okay, so I show that video was helpful. You could see how the whole process is so seamless, and that happens only because you're doing it day in and day out. So this is something I think we should aim towards, to how they go through in a systematic manner, and how they involve the patient and the family member. And I think you noted the whiteboard, which is being used to update the patient about what the goals are and how to go about it, and other information which is there. So this is video. I'm glad I got it and able to share with you guys. So I think let me.
Before we
Yeah, we're coming to the summary. So handing over is you've got to ask yourself the question: is there a multi-professional handover in your hospital? And are you using a standardized tool or a document to make sure that this happens? It could be a checklist or the document which I shared. And do you have a policy? And is there a training for the handing over? And finally, are you auditing the handing over process regularly? So if the answer to all of them are yes, you're doing a fantastic job. If it is no, then we have to improve. That's what we do all the time. Keep improving.
I thank Dr. Pari for his wonderful presentation. Thank you so much. And I'm sure all of you benefited by this. And it's really, I'd like to thank him once again.